I'm Laura Castillejos. I'm a nurse from Barcelona, Spain. And the last 10 years I was working in intensive care units. And in this video, I will talk about coronary disease. Lesson goals are coronary artery anatomy. We will see the anatomy of the coronaries, and also why are coronary arteries so important and what is coronary artery disease, a bit of history of ischemic heart disease, epidemiology, the risk factors, a bit of physiopathology, and finally, key points. So in this picture, you can see here all the coronary arteries of the heart. And these coronary arteries supply blood to the heart muscle. As with all other tissues in the body, the heart muscle needs oxygen-rich blood to function, and oxygen-depleted blood must be expelled. Coronary arteries run along the outside of the heart and have small branches that supplies oxygen to the heart muscle. We have two big coronary arteries, the left coronary artery and the right coronary artery. The left coronary artery supplies blood to the left side of the heart, included the atrium and the ventricle. And this left coronary artery divides in two branches, the anterior descending artery and the circumflex artery. And then we have the coronary artery that carries blood to the right ventricle and the right atrium, the sinoatrial node and the atrioventricular node, which regulate the heart rhythm. The right coronary artery divides into smaller branches, including the right posterior descending artery and the acute marginal artery. The other small branches of the coronary arteries include the marginal obtuse, the septal perforator, and the diagonals. So, why are the coronary arteries so important? So the coronary arteries carry blood to the heart muscle, and any disorder or disease of the coronary arteries can have serious complications by reducing the flow of oxygen and nutrients to the heart, and which can lead to heart attack or death. Arteriosclerosis is a build-up of plaque in the inner lining of an artery, and that causes it to narrow and become blocked, and is the common cause of heart disease. What is a coronary artery disease? So coronary heart disease or coronary disease, doesn't matter, is characterized by the buildup of fatty deposits along the innermost layer of the coronary arteries. Fatty deposits can develop in childhood and continue to thicken and enlarge through life. And this thickening, and called arteriosclerosis, narrows the arteries and can slow or block blood flow to the heart. The American Heart Association estimates that more than 16 million Americans suffer from coronary artery disease, and the leading cause of death, both men and women in the US. I attach here a video about what is coronary disease. It's a 2-minute video, so I think it's very interesting to watch it.
When a myocardial infarction strikes, the blood supply to the cardiac muscles is suddenly restricted. Starved for oxygen, these muscles begin to die, and within minutes are unable to keep the heart beating. The cause of this life-threatening attack is the obstruction of a coronary artery by a blood clot, resulting in most cases from atherosclerosis, which in the coronary artery is called coronary artery disease or CAD. In patients with CAD, atherosclerosis can begin to develop decades before symptoms arise. Since atherosclerotic plaques grow slowly. When a plaque ruptures and a blood clot forms, the threat of a vascular event becomes very real. Clots consist of activated platelets stabilized by fibrin strands. While activated platelets aggregate to seal the rupture site, fibrin formation is triggered by the coagulation cascade. An important part of this chain reaction involves factor Xa and prothrombin. When factor Xa encounters prothrombin, it cleaves prothrombin into thrombin. One molecule of factor Xa can catalyze the activation of 1,000 molecules of thrombin, which cleave fibrinogen into fibrin. Fibrin then assembles into strands. Thrombin also leads to further platelet activation via PAR receptors located on platelets, thereby increasing platelet aggregation. This activation doesn't only happen in the blood flow, but occurs predominantly on the plaque surface. Because of thrombin's effects on platelets and fibrin, it offers a specific therapeutic target for the inhibition of arterial clot formation. Vascular protection through reduction of thrombin generation is a promising approach currently under investigation for the prevention of myocardial infarction, stroke, or cardiovascular death in patients with CAD.
Here, this is a Framingham hair study, and the epidemiology of vascular disease is a study published in the Lancet. It's a very important journal. And here it describes all the history about the coronary disease and cardiovascular disease. So we can see here that in 1712, Heberden described angina. And then at the end of the 9th century, myocardial ischemia was correlated with coronary occlusion. From that moment, began the development of physiology, pathology, and clinical medicine. In 1919, the electrocardiogram appeared as a diagnostic method. And in mid-20th century, the Framingham study appeared in Massachusetts. This study was done by cardiologists, epidemiologists, and biostatisticians. It's a cohort study which investigates cardiovascular risk factors, such as hypertension or dyslipidemia, and changes. It says that changes in lifestyle changes in lifestyle then begin to be promoted. And in the last part of 20th century and 21st century, other studies focus on the primary and secondary prevention of pathologies associated with ischemic heart disease emerged. So here we can see that I was looking for epidemiology, and I found this information in the World Health Organization website. And it says that ischemic heart disease is the leading cause of death worldwide. More than 17 million deaths a year in the world. And in 2030, it's estimated that it will reach 23 million. So 50% of all deaths occur in developed countries and 20% in non-developed countries. So in Europe, there are about 4 million deaths a year from this disease. It's a long, it's a lot of information in this research. Yeah, you have here all the side. So what do we call a risk factor? So a risk factor is a characteristic of a population or individual associated with an increased risk of developing a certain disease in the future. So risk factors can be acquired and inherited and modifiable and non-modifiable. So here we have a lot, in this picture, you can see that we have a lot of modifiable factors and non-modifiable factors like genetic, race, gender, aging. But these risk factors can influence to suffer cardiovascular disease as arterial hypertension, diabetes mellitus, dyslipidemia, smoking, obesity, and sedentary lifestyle. Here in this picture, you can see all the physiopathology of the coronary heart disease, and it starts from chronic inflammation of the arteries in response to the biological effects of risk factors. So the macrophages, the white blood cells, which have the function of phagocyting all the foreign bodies that are introduced in the body, such as bacteria and waste substances from the tissues, will capture the oxidized LDL, a type of cholesterol, and will become from cells. And from all this, they will allow the migration of differentiation of monocytes into macrophages. So producing inflammatory cytokines, proteases, and free radicals. And this will consequently produce a lot of inflammation and tissue damage. There are two pathophysiological mechanisms of acute coronary syndromes. Plaque rupture is the 60-70% of the artery coronary syndrome cases, or erosion. Here, the artery coronary syndrome phases or representations can be chronic injury. Chronic injury is a physical injury that becomes chronic and the lipid component disappears or is reduced to vascular. And then we have this fixed or stable injury that it can produce ischemia at times of increased demand. So artery coronary syndrome, in this syndrome, a vulnerable plaque breaks and exposing the lipid content and forming partially or totally occlusive thrombus. And this can produce EST, elevated myocardial infarction, or non-EST elevated myocardial infarction. The key points of this talk are that coronary ischemic heart disease represents a major problem in developed countries with a high rate of associated morbidity and mortality. We can see that the risk factors are associated with a greater probability of suffering cardiovascular diseases. And risk factors are smoking, hypertension, arterial hypertension, dyslipidemia, diabetes, obesity, and habits and sedentary lifestyle. And also the evolution of atherosclerotic plaques determines the clinical presentation in the form of acute or chronic coronary syndromes. Thank you very much. I will continue this talk in another video. I'm going to talk about initial diagnostic approach to chest pain. Let's see the lesson goals. we will see which are the causes of chest pain, also how to do a clinic history, and we will see also the characteristics and types of chest pain, how we use the electrocardiogram in the emergency departments, also the troponin algorithm, and fatal and non-fatal causes. So we will see also what is the triple rule out concept. So we have different causes of chest pain. We can separate in cardiac causes and non-cardiac causes because not all the pains that, not all the chest pain can develop to a cardiac arrest or a coronary artery disease. So we have these cardiac causes, coronaries and non-coronary, like pericarditis, cardiomyopathies, valvulopathies, and mitral valve prolapse. And we have also these non-cardiac causes. So can be any disease related with the gastroduodenal, pulmonary, vascular, chest wall, and soft scars or psychogenic. So the clinical history plays an essential role because it guides us towards the patient types of pain and allow us to rule out multiple causes of severe chest pain. So it's essential to ask about the characteristics of the pain, and another very important aspect is to make a successful interview. So this is very important, and we have different tools to do it. But we can see here that we have different type of pains. We have the oppressive pain, pleuritic, burning, suffocating, different duration of this pain, hours, seconds, number of episodes, progression, different also location and irradiation, associated symptoms, and aggravating and extenuating with exercise, rest, or for example, with nitroglycerin. Sometimes when you see that the patient eats better with nitroglycerin, with the administration of nitroglycerin, so you can decide what type of pain is this. And it's also very important to ask for the origin of this pain, when it happened, like when it starts, this pain, and at what time, and what was the patient doing. Here, we have this very useful tool, and it's used to evaluate a patient in pain. So we can start asking the patient about the onset, then continue with provocation or palliation, quality, radiation, severity, and time. And these tools are very, very useful because you can use these in the emergency departments, and sometimes when we are very stressed, we can forget something. So it's very useful to have these scales or to use them in the emergency departments. Also, we have different chest pains. We have typical angina, atypical angina, and non-cardiac chest pain. So here I just attach a picture about of Canadian Cardiovascular Society. This is a classification system used to grade the severity of angina. But there are different classifications. So every country and every emergency department or paramedical use different classification systems. So here we can see that in the urgency area, we normally distribute the emergency levels from 0 to 5. And 0 is high priority, and 5 is the lowest priority. When a patient arrives at the emergency room with chest pain, we call that is a priority 2. So we would make a differential diagnosis, and after this, and within 10 minutes, it's very important to perform the electrocardiogram and interpret it by a specialized. So also troponin tests are requested if artery coronary syndrome is suspected. So troponin is one of the markers of myocardial damage. It depends on the electrocardiogram and the clinical history to diagnose the pathology. And it can be EST, elevated myocardial infarction, or non-EST, elevated myocardial infarction. It's also important to carry out the risk assessment based on the Teeny and Gray scales. These scales are used to stratify patients and with diagnosis artery coronary syndrome. Diagnosis, yeah, with artery coronary syndrome. So later, if the pathology is not clear, different complementary tests can be performed. Here, I just attach here how can we do electrocardiogram, because yeah, it can be very confused. So I put here where it can say actively. Yeah. So also finally, I want to explain you that there are fatal causes of chest pain as an obstructive coronary artery disease, aortic dissection, or pulmonary embolism. And we call these three causes the triple roll-out concept. Tests such as chest angiography may be needed to rule them out. Also, it's very important from the primary care centers that the prevention, primary or secondary prevention of this disease, because atherosclerotic cardiovascular disease incidence and mortality rates are declining in many countries in Europe, but it's still a major cause of morbidity and mortality. And over the past few decades, major risk factors have been identified. The most important way to prevent all these factors is to promote a healthy lifestyle through life, especially non-smoking, and effective and safe risk factors treatment have been developed. And most drugs are now generic and available at low cost. And nevertheless, the prevalence of unhealthy lifestyle is still high, and all these risk factors are often poorly treated, and even in patients considered to be at high cardiovascular disease risk. In this lesson, we learn about the chest pain is one of the most frequent causes of consultation in the emergency department. The detailed clinical history is very important to guide the diagnostic and stratify the risk of these patients. A typical angina chest pain must meet the three characteristics: oppressive central chest, occurs with effort, and calms with rest or nitroglycerin. It's very important to don't use nitroglycerin in right infarction. And in a patient with chest pain in the emergency department, a 12-lead electrocardiogram must be performed and interpreted in less than 10 minutes. And also is an action protocol based on troponin algorithm of 0 to 1 hour or 0 to 3 hours, and is very useful to assess the possibility of artery coronary syndrome. It's necessary also to roll out triple roll out in cases of chest pain through the medical history and complementary tests. We will watch another video about how we can reverse coronary artery disease.
More than 360,000 people died from coronary artery disease in 2019. It develops when the arteries in your heart become partially or fully blocked by a fatty material called plaque. As a result, your arteries narrow, meaning your heart muscle doesn't get the blood flow it needs. Signs of coronary artery disease include chest discomfort that feels like tightness or pressure, being short of breath, having chest pain, especially after walking upstairs. There are many ways to prevent coronary artery disease, but if you've already been diagnosed, is it possible to lessen its effects? Unfortunately, you can't reverse coronary artery disease entirely, and there is no cure. However, you can take steps to reduce your risk factors and manage the harmful plaque buildup impacting your health. Statins, short for statin medications, lower your bad cholesterol, which causes plaque to accumulate. Bad cholesterol levels below 70 milligrams per deciliter can potentially reduce plaque by up to 24%. Taking statins can also stabilize your existing plaque buildup, preventing further damage. People can sometimes have uncomfortable or harmful side effects after taking statins, however, so talk to your doctor about what's best for you. If you or a family member has been diagnosed with coronary artery disease, there are several treatment options to consider. The 4 common approaches are: 1. Make lifestyle changes. Embracing healthy habits is the best first step. Lifestyle changes you can make include quitting smoking, taking care of health problems such as high blood pressure, eating a heart-healthy diet, exercising regularly, limiting alcohol intake. Number 2, take medication. Your doctor may prescribe medications that will lower cholesterol, like statins, lower blood pressure, stop angina or chest pain, reduce the risk of blood clots, lower blood sugar levels if someone is diabetic. 3. Have a coronary stent procedure. With severe artery blockages, you might need a percutaneous coronary intervention, what's commonly referred to as an angioplasty. First, doctors insert a thin tube called a catheter into an artery on your wrist or leg. This tube has a deflated balloon at the end. Using X-rays as a guide, doctors direct the balloon catheter to the blocked artery. Then, they gently inflate the balloon, which widens the artery and restores blood flow. Finally, doctors implant a stent, which looks like a piece of scaffolding, to keep the artery open. Number 4, have coronary artery bypass graft surgery. With this surgery, doctors create new paths for blood to flow around a blocked artery. Surgeons carefully remove blood vessels from your chest, arm, or leg. Next, they connect these vessels to existing blood vessels on the heart, so oxygen-rich blood can once again flow. Deciding the best coronary artery disease treatment depends on how severe your symptoms are, your age, how many arteries are affected, how severely your arteries are affected. You should speak with your doctor and determine the best treatment plan together. Coronary artery disease is the most common type of heart disease. However, sometimes you won't know you have it until you have a stroke or a heart attack. Talk to your doctor if you have a family history of heart disease or are experiencing any coronary artery disease symptoms. Early intervention is key to keeping your heart healthy, both now and in the future.
So I hope you have learned in this talk And thank you very much for your attention. You can find me or you can send me any suggestion or question through my email, laura.castillejo+nor.no. Thank you very much and see you in the future.